I wanted to turn it over to Kristen Sullivan, who is the Executive Director of the Tobes Foundation. And she's going to share with us a presentation about behavioral health staffing shortages.
Good morning, everyone. Thank you for having me here today. I apologize if I'm a bit nasally. I'm on the tail end of a cold, so bear with me. In addition to being the executive director of the Tobes Foundation, I wanted to share that prior to this, I was working as a licensed clinical psychologist in an incarcerated setting with violent youth offenders, and many of whom experienced housing insecurity and homelessness as part of their narrative. So I appreciate from a very intimate point of view how homelessness can impact a youth's journey in life. But today I'm here to present broadly on mental health staffing shortages and how that's impacting behavioral wellness across sectors, settings, and populations. It's important to note that this work was a collaboration through the Santa Barbara Foundation, Youth Well, the County Department of Behavioral Wellness, as well as Cottage Population Health. Next slide, please. Okay, so before I delve into the staffing shortages, I want to set up how focusing on, I want to start by looking at the mental health care ecosystem as a whole. Mental health affects the whole community: individuals, families, communities, organizations, hospitals, schools, and government. I'm not sure if you can read all of these, but I'm sure all of you have been touched in at least one way. Employers are finding that work can be a significant source of stress. Family and community find that there's limited mental health literacy. Community supports are limited. The hospitals are finding overcrowding in emergency room departments and inadequate psychiatric availability. Mental health care providers are finding unequal access to providers with increasing demand for mental health services. Insurance is finding its difficulty navigating policy and coverage limits. Policymakers and governments are finding growing support for policies to strengthen mental health care and access, but funding remains inadequate. The educational system is finding limited faculty and staff training to manage student mental health concerns and support early intervention. And primary care physicians are finding insufficient mental health screening and few linkages to community mental health and resources. So with that, you can see COVID only exacerbated the pre-existing mental health crisis. Mental health the mental health system cannot handle the mental health needs of our community, and our community members are in crisis. Staff are stressed, burned out, underpaid, and are leaving the field. All right, now next slide. Oh, you're already there. Thank you. Okay, so how did we get here? So in September 2021, the Santa Barbara Department of Behavioral Wellness, with the help of stakeholders, conducted a mental health assessment to help understand the impact of COVID on individuals' mental health throughout the county. And one of the major findings was that there was a significant decrease in adequate staffing to meet the widespread and increased mental health needs of the community. Next slide. So in response to this, as a follow-up, a cross-sector of stakeholders held a strategy session to see how they could address the limited mental health staffing capacity throughout the county. That group came up with 3 strategies. 1, use a peer-to-peer model. 2, address constraints placed on the community-based organizations by existing funding requirements. And 3, prioritize and value Indigenous practice. While these strategies were identified to help alleviate the impact of mental health staffing shortages on organizations and to support the needs of mental health support, it became clear that understanding the positions and vacancies in more detail would further elucidate the problem and could help inform additional solutions. Next slide, please. So in November 2022, a survey was conducted through the YouthWell Community Collaborative, which is a large representative group of over 60 stakeholders. And it's important to note that this group is just for, they're focused on youth as defined ages 0 to 25. And they were asked to identify the top 3 challenges impacting youth mental health needs. And 33 out of the 45 organization respondents, so that's almost 73%, almost 3/4 of the group, identified staffing shortages as a top 1, 2, or 3 challenge for youth accessing mental health services. But if you look more closely at some of these other responses, you can also see that many of these also have to do with staffing as a bottleneck to services. So the second and third are waiting lists. And then if you look a little bit further down, there's also not having adequate health crisis. And so all of this really pertains to the mental health staffing shortages. Next slide, please. Okay, so what we did as a follow-up to the recent surveys and to the qualitative data, we decided we needed more data. So while it was generally understood that there are not enough providers to meet the mental health needs of the community, the specifics of these shortages needed to be better understood. We wanted to know where these shortages were. Was it a type of organization? Was it in a particular setting or geographic region? Was it a type of delivery model or language offering? And so in that partnership I mentioned, we set out to answer some of these questions. And as you can see here, I know you all are focused on South County specifically. And this is the breakdown of who was surveyed. So the majority of the organizations were countywide, meaning they had multiple agencies across the county, or I mean, multiple vacancies across county. 37% specifically had vacancies in South County, 7% had vacancies in Mid-County, and 5% had vacancies only in North County, and then 3% had vacancies outside of the county. Next slide, please. Okay, so it's really important to understand that this data represents a snapshot in time. Okay, so this was October 2022. We had 86 mental health providers in various settings across Santa Barbara County were asked to participate and to share with us their vacancies. So we had 87 invitees. We had 37 responded with a response rate of 43%, which is pretty good. And as you can see in this diagram, of the 37 organizations, they reported 122 openings. Within those 122 openings, they had 236 vacancies. And let me just clarify what that means. So that means that maybe, for example, there was an opening for a psychiatrist, but within that opening, they had 8 specific vacancies for a psychiatrist. So those are the difference between those two numbers. And this was an average of 8 vacancies per organization. So just think about your operations. What would it look like for you as a mental health provider to have 8 vacancies in your organization when you're trying to meet this increased demand for mental health services? I think that's what we're all seeing and experiencing and hearing. Next slide, please. Okay, so what this data showed us is that there's little consistency across position titles, making it very hard to compare. So really what that means is that one organization could be advertising for a therapist, another one could be advertising for a clinician, another one for a case manager. There were 67 unique position titles in the 122 positions that were open. So as employees searching for jobs, it's really hard to navigate what position means what when there's 67 unique positions across the field. Another interesting finding was that there were vacancies across the continuum of care. One thought was maybe, you know, it was all frontline staff or it was all psychiatrists and it was across the board vacancies throughout the continuum of care. Interestingly, however, there wasn't a single open position hiring specific for a psychologist. Being that it's a mental health field, it's surprising that no one's hiring for psychologists. The other thing that was really interesting was that the requirements within a specific category range. So for example, there were 39 vacancies across 7 agencies who are hiring for therapists and clinicians. So that's 39 openings, all seeking supposedly the same position, therapist or clinician. But the requirements that were required ranged from either just having a master's in a related field, so not even specific to the position, to actually requiring a licensed professional as a licensed social worker, licensed marriage family therapist, or psychologist. So again, it's very confusing as an employer, as an employee, how to navigate such a range. And as an employer, it's very confusing who you're trying to get if you're searching for a psychologist, a social worker, or a family therapist, because they all do different things. But when you're willing to hire any of them to fill a spot, it begs the question, are you actually filling the spot with the right professional? Next slide, please. Okay, so we were really interested in the pay range. And so as you can see here, this groups the pay ranges by organization type. So we have community-based organizations, county agencies, private agencies, health clinics and hospitals, and school districts. And this is the average low rate, the average low end wage and the average high end wage. And so usually when we asked for the data, they were giving us the low to the high. A lot of them were in ranges. And so we just split that and we averaged the low end across the board and the high end across the board. And this orange bar across represents what the living wages in Santa Barbara County for 2 adults with 2 kids. So that living wage is $31.92 per hour. And so you can see where the low and high end wages map onto that living wage across the different organization types. Okay, next slide, please. Oops. Okay, here, this is the average wage range by organizational type. So here you can see residential group homes, CBOs, community-based organizations, private agencies, county agencies. Sorry, these are the same slides. Okay, my fault. Can you go back and let me clarify something? Sorry, this was for a therapist position, pay range for a therapist. So this is how much a therapist gets paid across those. And so you can see if you're a therapist looking for a job, what's the likelihood of you wanting to apply to a community-based organization versus, say, a school district or a hospital or a health clinic? Now go forward, please. All right, my apologies. And so this is grouping all of the positions overall. And so you can see the pay range, how it's decreased when you average not just a therapist, but these are all of the positions within the residential group home, the CBO, the private agency, county agency. And again, we have the living wage is $31.92 across the board. And then we have how the various agencies compare. And again, where would you want to work if you were applying for a new position in mental health field? Would you be working for the residential group homes, the county behavioral agencies, or would you be looking for a health clinic or a hospital or a school district? Next slide, please. Okay. So this is just to emphasize the point that's made that this is not that behavioral mental health workers are not on average being given a living wage. So when we exclude the medical professionals from the data, so that basically means we're taking out the nurse practitioner vacancies and the psychiatric vacancies, the low end wage on average, the low end wage range on the low end ranged from $15.50 to $42 with an average of $25.32, and compare that to the living wage. And then on the high end, we had a range of $15.50 to $62 with an average of $31.88. Compare that to the living wage. You can see that only 61% of the only 61% of the high-end wages are below the living wage. That's terrible. Next slide, please. Okay, this is to show how the pay range varies by educational requirement. And as you can see here, it goes by increasing educational requirements. So no educational requirement, a high school diploma, GED, associates in a related field, bachelor's in a related field, master's, and so on to a medical professional. But here I wanted to just highlight, if you're a high school grad or a GED and you're interested in the mental health field, and you can get between $20 or $24 to work frontline, maybe frontline staff, maybe shift work, maybe overnights, dealing with some of the most intense, high risk, needy populations. Or you could work at one of our local corporate coffee companies and get higher wages with better benefits and less burnout. Where would you want to work? Where as a society are we putting our values when we're incentivizing these positions? Next slide, please. Okay. This is a lot of data and I'm not going to go through it, but this is just to this is just to give you an idea of the various names for a therapist or clinician. So clinic therapist, school-based therapist, clinician, therapist, bilingual therapist, and then how all these positions with very similar names have very different requirements. And those different requirements have very different pay ranges. And then it's really important to note that the majority are either preferred or required bilingual Spanish, which is a very important piece of the puzzle. Next slide, please. So there's a lot of contributing factors to these mental health staffing shortages. We have, like I decreased mental health demand with higher severity because of the need for mental health providers, there's increased caseloads. So because we don't have enough providers to go around, everybody has to have increased caseloads, which increases burnout, which then makes less available, and there's less available support for both providers and clients, which increases turnover, which leads to less capacity for service providers. And this is all impacted by the siloed and fragmented system in Santa Barbara, the high cost of living in Santa Barbara, the low wages that I outlined in this study, insurance barriers, and the psychiatric shortages. Next slide, please. And so we're constantly stuck between this mental health staffing shortages, which is going to make an impasse, a bottleneck, limiting the access to mental health services. We can talk about strategies and ideas and ways to get around mental health staffing shortages but bottom line is, unless we increase the mental health staffing workforce, we are going to continue to run into bottlenecks and staffing shortages. So in conclusion, next slide, please. How do we as a community address the more critical need to retain and recruit mental health providers that are linguistically, culturally, and ethnically diverse across all behavioral health training pipelines for positions throughout the continuum of care? And that is it. Thank you for your time and attention. Questions?
Thank you for compiling this data. It's overwhelming, and I think we knew that this is what was going on, but it's nice to see it in black and white. So it's no longer kind of a I think or I heard. And I think it helps us really start to move forward to define what next steps are in a concrete way. So thank you.
Yes, Kristen, thank you. This is Gina. I thought that leading into addressing the needs for the unsheltered and homeless community and these people who are not getting services originally and cannot access any kind of service, of where they're going to end up. I mean, it's really critical that we understand what is going on in this community. So I really appreciate the thought and preparation of this.
Thanks.
It's a little shocking too.
Yeah, it was a lot. Sorry.
No, it's just shocking to see it in numbers like that. Sobering.
There's a question. Are the slides available? Landon, are you able to give out the slideshow presentation?
I can do that. And I also put the link to the full report in the chat window as well.
Yeah, and that's actually a good point. If you don't want to read the full report, on the YouthWell website, there's also an executive summary too that highlights some of these points. And a great question. Do you have policy recommendations for funded elected leaders, etc.? If you go to the executive summary on the YouthWell website, there is recommendations by funders, employers, education, and policymakers. I'm reading the chat. Was there a school district salary, as they are often let go, paid during the summer? We didn't get into that specific. We based it on whatever they reported, and so we didn't get into the specifics of the school-based salary.
For our homelessness service providers on the call today, I'm curious, what are some of the positions that are most needed, that are not filled right now within behavioral health for our people experiencing homelessness?
Well, I don't want to jinx myself, but I'm fully staffed finally. After coming to this group saying we've been shorthanded, we're actually fully staffed. But with our other department programs, we have experienced shortages with hiring therapists. We have over 20 vacancies within the Department of Behavioral Wellness right now.
Can I ask a follow-up question, John? What contributed to you to be able to fill those positions? How are you attracting and retaining those workers?
A couple factors were staff that had gone from other homeless outreach providers and come back to that were with behavioral wellness. They came back to us. And in the Lompoc region, I was really fortunate to have a bilingual therapist who actually lived in Lompoc that had an interest in working with the homeless up in the West region. So I was very lucky to be able to hire him, and then already have a caseworker that had worked with him before with another had another job at Transitions Mental Health Association up in Santa Maria, so I was really lucky to have both of them come on at the same time. Though I will say that, do we need another therapist to work with homeless services in the South? Definitely there is a need. I'm having the Lompoc therapist assist with some assessments to get clients open down here in the South right now, because there's just such a need down here.
There's a question from Lizzie in the chat, or more of a suggestion. Lizzie, would you clarify a little bit about what you mean by that partnership?
Sure. I just I think what you shared is so it's sad, it's frustrating, and it's important for I think even our county supervisors to know this challenge. And until it can be addressed, I'm wondering is it possible to partner with different agencies, hospitals, clinics, places that may not be experiencing the same staffing shortages, so that they can help fill in the gap and make sure that the folks that are most vulnerable are getting the services that they need if they can't get that through nonprofit organizations.
I think that's a really good question. I did present this to some government representatives, including a city representative for a city council person, an assembly member, and the senator's office. So I am trying to advocate at a higher level to see how we can address the staffing crisis. So that is something that we're working towards. We don't have, as you all can imagine, we don't have any easy answers. I think looking at working in partnership with the private sector, we have a really high number of therapists, across licensing levels that work in private practice that do not take insurance. And so looking at how we can work with insurance companies to get private people in private practice insured, making the reimbursable rates more comparable, making the billing reimbursements easier, looking in partnerships with the hospitals. How can we, is there a way to build on systems that are pre-existing? These are all things that we're throwing around and in conversations about. So again, I don't have any answers, but I think this type of out of the box thinking of how we can work together and partner is really, really important. And it's going to be ultimately part of the solution.
So Kristen, I'm Nancy Gaston. I am a therapist both in private practice. I have to work 2 jobs to make ends meet. So I work both in private practice and I work at Good Samaritan Shelter, working with Be Well and SENCAL clients on a regular basis with co-occurring disorders oftentimes. And I agree, the reimbursement rate in the private practice that I work at, we only take SENCAL and then private pay, cash pay. Because the reimbursement rates are so ridiculously low. If we look at even just the return on investment of our education, and a master's level clinician and what we earn in regard to people who don't have master's degrees, it's ridiculous, and it's a huge discrepancy. And I'm just listening to the conversation on the behalf of our director, Good Sam's Mental Health, just to see what we can do. We are understaffed. We cannot open up as many clients as we'd like to, because right now there's one and a half of us why people are out on leave for various reasons, and we just can't get to everybody that needs help. However, on the reverse side of that, because of the particulars of the populations we serve, we talk about this in our weekly meetings all the time, the amount of people who do require services don't always show up. And so we need to find ways to encourage them to prioritize their mental health and their needs as well. So it's multifaceted, this problem.
Thank you, Nancy. I appreciate you sharing that. I didn't touch on this point in the presentation, but in the chart, part of the point was to highlight how the different educational requirements do not map onto the pay ranges. There's a huge investment on the part of the clinician to get, to get a higher and higher level of credentialing, and yet it's not reciprocated from the employer standpoint. So I'm glad you highlighted that.
And I see more just suggestions and questions in the chat window, different ways to get creative around benefits, working with landlords to create housing subsidies, and then also just looking at all the different funding sources for our different agencies to see how that impacts the way that they staff.
I think that's also something that we're hoping to do, is to really map out the funding sources, especially with the state's recent focus on behavioral health, and understand where the state money's going, and so that we can we can create public-private partnerships, and private philanthropy can understand how best to leverage their more limited dollars to dovetail the money that's coming in from the state. But it's really hard to do from our standpoint as a funder, because we don't really understand where all the money is going. So understanding those pipelines and where the money is going and isn't going is something we hope to learn.
Are there any education reimbursement programs that would motivate therapists and clinicians and the psychiatrists to basically volunteer hours in order to reduce their education costs and pay back their student loans faster?
Great question. It's similar to the state funding. There are a number of reimbursement options, loan repayment plans, but they're time and sensitive, meaning like, it's 4 years or 10 years. And sometimes that's a long time to wait with, required payments. And again, it's really hard to navigate when you're in the thick of it as a student. If you're trying to work full time, sometimes 2 jobs, and you're trying to get the next credential, the last thing you really have the bandwidth to do is to navigate where the additional funding is coming from. So looking at ways to work with employers to help connect those dollars with the students that are in training would be a really great idea and really useful.
I also find too that many graduate programs in mental health aren't necessarily teaching or focusing on how to work with homeless and mental health, and they're also not focusing on how to work with severe persistently mentally ill. Many of our graduate school programs are really focusing on private practice and how to become a private practitioner, which is lovely, but doesn't necessarily meet the needs of our community, of our agencies. And so that would be something interesting to have a conversation with our schools about helping them expand their curricula to what the community needs, and just a thought.
Gabriella, that's excellent. We've talked about that at other partnership meetings about just that, is that the nonprofits and CBOs are finding that when they do take on a student in training, they are so green or so unprepared that it takes more money and more of their staff hours than they have time to invest in a student to train them up, than to have that student, turn around and leave to go into private practice. And so we have talked about how we can work with the local schools to really make sure we're matching the curriculum and the training and the pipelines. And I think this goes into the pipelines, like making sure that students in social work who are being trained into social work are being put into social work positions and not necessarily expected to do some of the therapeutic work that they aren't trained in. And so working with the schools and the employers to make sure that the training is mapping onto the position and the position is actually getting the students that have the right training, I think would be really helpful.
So I'm going to keep us moving. We'll have time to continue this conversation as we keep going with the meeting.